information in the class. We really are that close to the end of the semester. So I just put up the rest of their schedule so you could see it and start thinking about planning. All right, so there's no class Wednesday or Friday of this week. That's Thanksgiving. Have a good one. Next Monday, we'll do exam 3 review, and the homework for this 2 chapters will be due then, so I'll remind you of that then. Next Wednesday, so a week from this Wednesday, is exam 3, and we talked about that. Open notes, not open book, not open internet. I would encourage you to study for sure, because I think if you just show up with your notes, you're going to run out of time, and you're not going to do well. So do study and get organized, because you're going to have 60 minutes, so have your notes organized so you can find stuff easily. All right? Then next Friday, there's no class. And the reason for that is I used to do a final exam review, but students in the past have commented that it's not a good use of time, basically, because we can go through questions all day long, or we can go back through the material. But I know how you study for the final, and that is you look at the questions and answers from other assignments. So unless there's something that comes up that we want to meet on Friday, or another option is if you wanted to take the final exam on that Friday, we could do that too. So think about that, and next week we'll talk about it for sure. But then 12/9 is the Monday of finals week. It's a normal class day. The schedule changes for Tuesday through Friday. Monday is the last normal class day, so I give my exam then, because that way you're free of it. You can concentrate on your other final exams. And please, 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 you've probably been notified a bunch of times already, but the course evaluations are open. They close on December 9th. So please, please do your course evaluations. To the administration, it matters a great deal. So we like to see lots of participation in the eval, so please do that. Anybody not know how to find those? No? Good. Okay. And they really will keep hounding you until you do them, incidentally.
Yeah, I think even when you do them, they still do them. Yeah, so I know. Some people don't do it just to fight.
And it's because the administration thinks it's so important. That's why everybody hounds you about it.
Doesn't train the teacher very well.
What?
So it's like a light scale how you're doing, and then
yes. But that's what it's all about. All right. So last time we introduced really the hormones that control the female reproductive system. So the major players are GnRH, FSH, LH, and then estrogen and progesterone. Right. So GnRH comes from the hypothalamus, and it triggers the production of FSH and LH. FSH triggers the formation of an ovarian follicle, and the ovarian follicle produces estrogen. That estrogen eventually triggers the release of LH, right? And LH triggers ovulation. The follicle becomes a corpus luteum. The corpus luteum creates progesterone and estrogen. Progesterone inhibits GnRH and affects the endometrium. All right, so if we put all that stuff together into one picture, this is a good one. So this is sort of the female reproductive system in a nutshell, the physiology of it. The anatomy of it we looked at last time, but the phys here is all in one temporal chart, so to speak. All right, so to orient you, along the bottom is days, right? So the menstrual cycle is typically 28 days, 4 weeks. So we start at 0 and we go to 28. And then up here, these are the pituitary levels. So these are the pituitary hormones up here. This is what's happening in the ovary here. This is the hormones coming from the ovary are here. This is what's happening in the uterus, particularly at the endometrium, right? And then these are the different phases. So we start here with the menses. So estrogen and progesterone in black have fallen off. You can see from the last cycle they plummeted. When that occurs, the endometrium sort of breaks up and sloughs off, because without estrogen and progesterone, there isn't the signal to support it, right? So you can see the endometrium kind of falling apart, and then it gets, at the end of menses, it's at its thinnest, right? So all that's left is the basilar layer, like we talked about last time. And then if we look up here at the pituitary hormones, we can see that FSH, which had been very low at the end of the cycle, started to rise. It starts to rise here, and it sort of stays steady. In response to that FSH, one follicle in the ovary develops, right? So we have a primary oocyte in here. It starts to form this little fluid-filled space called the antrum, and then eventually it forms a mature follicle that looks like this. So we have the ovum here, and then we have this sort of fluid space. This follicle is a hole. So this is the hole, even though it's filled with fluid. This structure produces estrogen, and lots of it, right? So as the follicle is developing, we can see the estrogen level going up and up and up and up and up. When estrogen levels get very high, like about here, they trigger the release of luteinizing hormone from the pituitary. So we get this spike, and then about a day later, here's the difference, about a day later, we get ovulation that occurs. So, your handy-dandy ovulation predictor kits that you see in the grocery store, and they detect LH. Because when LH goes up, ovulation follows usually within 24 to 48 hours. So we get the LH spike, we call that, triggers ovulation. Now, once ovulation occurs, the follicle is sort of broken, because the ovum sort of pops out of the wall, and it leaves this sort of crater behind. So after ovulation, we see a sharp decline in estrogen and a sharp increase in progesterone. So we see this kind of cross right here. That is luteinization. In other words, the follicle has become a corpus luteum. The corpus luteum produces estrogen in lesser amounts than the follicle and progesterone, right? So after ovulation, we get corpus luteum, boom, boom, boom. These two, they produce estrogen, which we see start to increase again. And then the principal one is progesterone. All right, so what about what's happening in the uterus? Well, as that estrogen is going up and up and up with follicle development, the endometrium is getting thicker and thicker. So we call that the proliferative phase. It goes from thin to very thick under the influence of estrogen. After ovulation occurs and the corpus luteum forms, now we get progesterone. Progesterone makes that endometrium secretory. In other words, it starts creating things and secreting things. The things that the fertilized egg will need to transform itself into a fetus. All right. The corpus luteum has a limited lifespan. If there's no implantation, in other words, if there's no pregnancy, the corpus luteum starts to disappear. We call it a corpus albicans at the end. And as it starts to disappear, what it makes disappear. So progesterone falls off, estrogen falls off, this other one, inhibin, falls off. We don't pay that much attention to inhibin. As those things drop, particularly as progesterone drops, we see FSH start to go back up. So the light blue line, as this one goes down, FSH goes up. And that's because progesterone blocks the hormone that triggers the release of FSH, like we saw in the previous slide. All right. So progesterone falls, estrogen falls. When that occurs, the endometrium starts to fall apart, and we're back where we started again, right? So this is sort of a nice putting all the pieces together in one cycle. So I recommend that you spend some time looking at this and going through the pieces or the phases. An interesting point down here is the basal body temperature, which is the temperature, the core body temperature, first thing in the morning after waking, There is a change in that over the ovarian cycle. So in the follicular stage, where the follicle is developing, it's at 36.4, and in the luteal stage after ovulation, it's at 36.7. So, one ancient birth control method is called the rhythm method, and what you want to know there is you want to know when ovulation has occurred, because the female is not fertile in this point, but she is fertile at this point, right? Because there's an egg out there, see? So if you know where ovulation is, you can plan around that. So you have sort of the infertile time here, and then the fertile time here, and it's represented in basal body temperature. All right. So the interplay of these hormones has made it possible for there to be hormonal birth control for the female because of particularly these relationships that we talked about before. Estrogen inhibits LH if it's at a low amount, and progesterone inhibits GnRH, which prevents FSH and prevents a follicle from being created. So if we give a female small amount of estrogen, small amount of progesterone, it blocks both ovulation and follicular development. So essentially it halts the ovarian cycle through inhibition of GnRH and LH. So probably the most common birth control method in the world is that hormonal variety. So that's oral contraceptives usually have a mixture of estrogen and progesterone. Today, there are quite a few products that use progesterone alone because estrogen can have some side effects. It increases your risk for breast cancer, increases your risk for certain clotting disorders. So because of that, there's been a lot of movement towards a progesterone-only system. So one is a pill you take every day. One is a depot injection. A depot injection is just where the hormone is given into the muscle, and because of the suspension of fluid that it's in, it basically slowly leaks out into the blood over time, usually about 3 months. Other birth control strategies, there are barrier methods. If you can stop the sperm and egg from meeting, so to speak, there can't be fertilization. So the male condom does that, the diaphragm does that. The diaphragm fits over the uterus, or I'm sorry, the cervix, effectively blocking the path. They have to be fitted because not every woman is different, so the diaphragm has to be the right size to make that barrier method work. An IUD is a device that is implanted in the uterus. It basically sits in here. If you look at this shape, one of these arms would be in each of these corners. And IUDs prevent pregnancy in multiple different ways. Some IUDs actually have some hormone in them that leaks out. This is a copper IUD, which prevents implantation, so there can't be a pregnancy. Again, this has to be put in by a physician or a healthcare provider, and it ultimately should be taken out by one too. And then post-coital contraceptives. This is the Plan B, or the after-sex pill. And essentially, if you sort of spike the hormone system here with a whole lot of progesterone, it can block the signal for a pregnancy to continue, as we'll talk more about in a little bit here. And then the surgical ones, a vasectomy, the vas deferens, are either clipped, a clip is put on them, or they're cut. In this case, they've been cut. And a tubal ligation, tubes being tied. We don't actually tie the tubes, we cut the tubes and then we tie them with a suture. A common one today is that we use a clip instead. So instead of cutting it, we clip it. The idea there is if you wanted to reverse it, there's the possibility you could. But there is no guaranteed reversible surgical strategy. Anytime you do something surgically, chances are it's going to be permanent. All right. And of course, the reproductive system has problems that are associated with it. One is BPH, benign prostatic hypertrophy. because the urethra passes through the prostate gland, if the prostate gland gets bigger for some reason, it will start to impinge on the urethra. So you hear about this one on television in the commercials because there's some really good medicines for it that help to shrink the prostate gland so that the problems associated with urinary blockage are alleviated. Yeah, there's a whole bunch of them that are out there now. But yes, Flomax is one of those. Usually it's 56-year-old men talking about urinary symptoms. That you can be pretty sure that that's a
There's
prostate
one out there now that
commercial.
this guy talks about like protecting his manhood or something, and it's like briefs that men can like go in. And I'm like, why would they put that on TV?
The new one now is low T, low testosterone syndrome, which has been recently described, and who knows if it's real or not. Here's a mammogram. All of you will one day have pictures like this in your medical record. This is a mass. So this is the kind of thing you would want to take a biopsy of, take a little piece of it and see if it's cancer. Testicular cancer, we all know about Lance Armstrong. Ovarian cancer is particularly nasty because it has no symptoms until it's very advanced. So one of the reasons why women have, regular pelvic exams is to try to detect an ovarian carcinoma. But typically, this is a killer because by the time it's detected, it's too advanced to do anything about it. It's already metastasized, in other words. And then cervical cancer, this is another reason why women have pelvic exams. The cervix is an epithelium. Epithelia have a tendency to be more cancer-prone than other tissues. So one of the things they do in the pelvic exam is observe the cervix to make sure this is what it's supposed to look like over here, nice and smooth and shiny. But here we have tissue that's irregular. So one way to detect cervical cancer early is with a pap smear. You scrape a few cells out of this off the cervix and send it to the laboratory and identify anything abnormal. All right, so all things you'll learn about more later. Okay, we're going to do a few questions, but not all of them. Okay, the surge in luteinizing hormone that occurs during the middle of the ovarian cycle triggers which of those things? Do you get the question? Yeah, good.
I don't think television.
All right, good. Almost all of you got that. That's E, ovulation. So FSH triggers follicle maturation. As the follicle matures, it makes estrogen. When that estrogen level gets high enough, it triggers the LH spike. The LH spike precedes ovulation, so it triggers ovulation. And then after ovulation, we get into that luteal phase where the corpus luteum is running the show, so to speak. All right. Here, we'll go back, sorry. I'm being confusing here. Okay, a rise in the blood levels of follicle-stimulating hormone at the beginning of the cycle does what? We got a split between A and C. So FSH is responsible for follicle maturation, so that's A. Menstruation begins when the corpus luteum disappears or breaks down into the corpus albicans. The estrogen levels drop, the progesterone levels drop because that corpus luteum was making those hormones. without those hormones, the endometrium falls apart. So it goes back to its basilar layer, and the functional layer is shed as the menses. Okay. All right. So then we get into chapter 26, and like I said at the beginning of this section, I'm only going to test you on what I've covered here, because chapter 26 is in many ways it's like a course in itself, and it doesn't the yield isn't very high. So I've picked out the things that I think are important, and at least give you a better idea than you probably already have of how we go from fertilized egg to delivered offspring. All right, so prenatal development includes everything from fertilized egg to delivery, right? And we break it down into two phases, embryologic and fetal. And there is a difference. Embryologic development is you can think of it as the body is changing shape. The offspring is forming, right? Because, early on we have to go from single cell fertilized egg, right, to something that resembles a human being. And so all those changes in shape that you can imagine would have to go from simple to complex, we call that embryology, or the embryo. So for the human, that goes until about the 9th week. So for the first 2 months, the offspring is changing shape and developing all the structures, things like bones and muscles and organs and skin and brain and hair and all those things. Because the single cell that we start with doesn't have any of those things, right? So far and away, the first 8 weeks is the most critical for development. Because a tiny little thing that goes wrong in that first 8 weeks can result in a catastrophic, problem later on. Because it's when everything is forming. So cleft lip or cleft palate, which some of you may have seen, that's an embryological defect. In other words, something went wrong between week 1 and week 8 that meant that the center of the face didn't come together right. So it's a critical time. And the tricky bit is typically women don't know they're pregnant during part of the embryologic period, right? So folic acid, for example, is necessary for the brain and spinal cord to form properly. Folic acid is a vitamin, so it's something that isn't necessarily in all the foods that we eat. So, we had this problem of spina bifida, malformed spine and brain, and we knew how to fix it, folic acid, early in pregnancy. But the trick is, how do you give it to women if they don't know they're pregnant? So now folic acid is one of those things that are added to all kinds of things like flour and bread and cereal and stuff like that, because we want to make sure that any woman who's pregnant for that first 8 weeks has plenty of folic acid around. So at the embryological period, the first 8 weeks is the most critical. After that, pretty much all the parts are there, and they're in the right shape. They're just not big enough yet. So fetal development, which starts at week 9 and goes all the way to week 39, basically the now formed embryo, the embryo forms into a fetus, it just gets larger. So the organs are all present, the shapes are all there, they're just not in their final form, so to speak. All right, so embryo and fetus. All right, so it all begins with a fertilized egg, right? We've all heard this story before. So here's ovulation. It's bursting out of that follicle. The ovum ends up in the uterine tube. The typical site of fertilization is right about here. So the sperm have made their way all the way up here. Immediately after fertilization, cell division begins. So we're zooming in here. We have, but note that the size isn't changing. So, we have a big cell, and now we have 2, right? And then we have 4, and then we have 8. But the cells are getting smaller, so the whole ball, the whole thing, isn't getting any bigger. That kind of makes sense because there's no nutrients in here, right? So you can't build something with stuff you don't have. So all of the nutrients that are allowing this cell division are all come from the ovum. So the reason the ovum is so big and is given all the resources of multiple cells is so that it can do this trick. So as it's traversing the uterine tube on its way to implantation, it's dividing and dividing and dividing, but it isn't getting any larger, right? All right. So by the time implantation occurs, which is down here, the fertilized egg is then called a blastocyst. And I'm not interested in you knowing like morula and blastomere. So it's the blastocyst is what implants. All right. So what does that look like? Okay, so here's the blastocyst. You know, it looks like just a big ball of cells. And as it's landing, its inner structures are changing, right? So outside, it's a big ball of cells. Inside, there's a ball here or a mass of cells here, and then there's a big fluid-filled space, right? The inner cell mass in here in the light blue, that is what's going to go on to become the embryo. And this outer piece is going to go on to become the amniotic cavity or the amniotic membranes, right? All right, so here's the endometrium. It's gotten thick under the control of estrogen. It's gotten secretory. Glands get formed under the influence of progesterone. So when that lands, there's plenty of good stuff in here to power the rest, right? So blastocyst lands, it attaches. So here's attachment. And then it starts to burrow. So this cell mass kind of works its way down into the endometrium. Again, note this. No need to know all this specific stuff. Just know the blastocyst attaches, it starts to burrow, and then eventually it completely buries itself under the endometrial lining. So here, implantation has been successful. So it made its way through the wall, and then the wall closed in behind it, right? And now we have an even more complicated structure. So while this burrowing has been happening, now we have the inner cell mass in light blue. That's going to go on to become the embryo. We have another, we have what's called the yolk sac, which will go on to become part of the digestive tract. And then out here, we have what will go on to become the amniotic cavity, right? So implantation. Once that occurs, the next part is to make a placenta. Because the endometrium can supply that developing embryo without any special structure, but only when it's very small. As the fetus is going to get larger and larger, it's going to need more and more resources from mom. So there needs to be a better system that develops for that. And this is what that looks like. So here's the uterus, right? Here, the baby has been taken out in our picture here. In case you're wondering where the baby would be, it would be in here. But we're looking at the placenta. The placenta is this round thing. If in your rotations through obstetrics, the baby gets all the attention, right? And the placenta, or the afterbirth, nobody even pays attention to it. But it's a fascinating structure. So if you have the opportunity, you should at least look at it so you can see what a placenta looks like. But it's very disc-like. One side is very smooth. That's the baby side. And then the other side is very sort of rough and vascular, and that's mom's side. So between those two, the placenta is a remarkably simple organ for all that it does. And there's a baby side and a mom side. So half the placenta the baby makes, half the placenta mom makes, right? Now the part that gets delivered after the baby, that's the part the baby made, because mom's part is clotting up and closing down. But here's the sort of structure that makes it work. So we have an artery that's we have a vein that's going back into the baby carrying oxygen-rich blood. That's why it's in red. Again, one of the few places where you'll see a red vein, right, is in the baby, is in the fetus. So we have two arteries that go out to the placenta. We have one vein that goes back. And what they form are these sort of tree-like structures. So baby's blood is in these trees, right?
We call them chorionic villi. Villi, is hills. I think it looks more like a tree shape, right? So the arterial blood comes out, venous blood goes back in. Surrounding those villi, so the baby made those, the baby made the villi, but mom has made these pools of blood around these villi. So that's her side of the placenta. So mom's blood is here, baby's blood is here. Here's where people make a common misconception. Mom and baby do not share blood. Their blood stays in their own separate cardiovascular systems. So even though mom's blood comes right next to baby's blood, there's always a cell membrane in between, right? So mom's blood doesn't circulate through the baby. This is how a baby can have a different blood type than mom does, because the blood cells don't ever cross. All that crosses is nutrients and waste products. So crossing that narrow barrier between baby blood and mom's blood, oxygen is going into the fetus, carbon dioxide is going into mom, right? Because baby's using mom's lungs. Nutrients go into the fetus, waste products come out, because the baby is using mom's digestive tract to get nutrients and mom's kidney and digestive tract to get rid of waste products. So it does its job, which is to provide for the baby without the baby having any access to the external environment. So, and it's very simple. We've just got, you take baby's blood, put it very close to mom's blood, and these exchanges happen through diffusion. So there doesn't have to be any fancy, physiology here. The oxygen goes in, carbon dioxide comes out, just like as though the baby were any other tissue in the body. Now, it is true that the fetus lives at a much lower oxygen concentration than we do once we start breathing air. So again, when you're in your obstetrics rotations, note the color of the babies when they're born. They're usually very blue or purplish, right? And then in those critical first couple of minutes, they pink up. And that's because for the first time in their life, they're breathing oxygen at a concentration much, much higher than they ever got during development. So it's like a C-section. Before they cut the cord, you can see the true color of the baby, and it's very purple. And it's just a sign that the fetus lives at a much lower oxygen concentration. It's the only way mom can do it, because mom's got to move oxygen from air all the way to fetus, and she can't do that as well as she can for herself, essentially. All right. Okay, so in terms of anatomy here, I just want you to know what a chorionic villi is, and the sinusoids are where mom's blood is at. All right. Okay, so we all know that hormones and pregnancy go together, right? But what hormones are we talking about? Well, if implantation occurs, the developing placenta, so we're sort of back here, these extensions, these purple cells, they're going to develop into the placenta. As they do so, they release a hormone called HCG. So we saw that the placenta baby side is chorionic villi. Well, that's the C in HCG. Human chorionic gonadotropin is a hormone produced by those chorionic villi. So where do we find chorionic villi? In a placenta. So the only time you have HCG circulating is if you have a placenta. If you have a placenta, you are in fact pregnant, right? So the reason we use HCG to detect pregnancy is because there's no other way you can have an HCG level than if you have a placenta. Now, it is true that sometimes certain reproductive cancers can release HCG as well. So there are times where you can have a positive HCG and not be pregnant, but it means there's something else going on. So you still would get worked up for a cancer. All right. So what does HCG do in the body? Clearly it's not just there so we can tell if a woman is pregnant or not. Its role is to keep the corpus luteum from disappearing. Remember we said if no implantation occurs, the corpus luteum lives about 10 to 12 days, right? If HCG is present, in other words, if there's a placenta, in other words, if there's been implantation, the corpus luteum stays, and it becomes a corpus luteum of pregnancy. And it lasts about the whole first trimester, and it produces estrogen and progesterone. Without estrogen and progesterone, no pregnancy can go on. So they are critical. Without estrogen and progesterone, the endometrium falls apart. No endometrium, no placenta. No placenta, no pregnancy. So we have to have a source of that. And the placenta is so tiny in the first trimester because the embryo is so tiny that it can't produce enough estrogen and progesterone to keep itself alive. So the corpus luteum does that. So the corpus luteum of pregnancy. Now after that first trimester, now we're into the fetal development stage. The placenta is large enough that it starts producing progesterone and estrogen instead. So after that occurs, so at the end of the first trimester, the corpus luteum does go away because the placenta has taken over that role of secreting progesterone and estrogen. All right. So when the baby's born and then the placenta is delivered, right? When the placenta detaches during delivery, that's the source of estrogen and progesterone, right? So if you remove the source of the thing, those levels are going to drop. And the plummeting levels of estrogen and progesterone is actually what triggers the release of prolactin from the pituitary, and then prolactin is what turns milk production on. So it stimulates the now developed mammary gland, because remember we said that during pregnancy, the mammary gland forms ducts and glands that aren't usually there. Then those glands, when the progesterone and estrogen drop, start producing milk. So usually it's a couple days after delivery that milk production actually begins. Moms and grandmothers and parents get very freaked out about that, but it's nature's way. The baby is born not needing really anything for 48 hours. So even if mom doesn't have milk production yet, chances are baby will be fine. All right. So I like this picture. This is new in this book. I've never seen a picture like this before. But it shows you the real estate challenge in the human. For our size, humans deliver enormous offspring. If you look at other animals, what is born are much, much smaller proportionally to the animal. If you think of a kitten, they're very, very tiny. Well, in the human, we deliver one large offspring at a time, usually anyway. So in the female abdomen, there gets to be real competition for real estate. All right, so this is how it looks normally, right? Here's from the side. So here's the liver, here's the stomach, large intestine, small intestine, plenty of room for things to move. Here is full-term pregnant, right? So the baby has basically taken over the whole pelvis and bottom part of the abdomen. This is mom's GI tract that is being shoved up into her lungs, basically, shoved up underneath the diaphragm. And everything gets compressed in here. So GI problems are very common in late pregnancy because your digestive system is literally being crammed all together. So constipation becomes an issue and poor digestion and things like that. So because here's the liver shoved way up against the diaphragm, the stomach, the small intestine. So that's one piece. Down here is the poor urinary bladder that's being basically squeezed from the top by the baby all the time. So one of the reasons why pregnant women have to go to the bathroom all the time is they've got a baby sitting on their bladder. Quite literally they do, right? And there's only so much that the anterior abdominal wall can bear in terms of holding the weight of the baby. The bones are all down here. So we've got to keep the weight of the baby on the bones or else mom's going to tip over, right? So where does it end up sitting? Right there on the urinary bladder. And also, it pushes here on the back and the rectum on the back as well. So you get problems from urination and defecation both with giant babies sitting there. All right, so, and also look at the curvature of the back here too. We call that the sway back of pregnancy. And again, as more and more mass gets out in the front, the correction is the woman has to lean back, essentially, to keep that weight on her pelvis and down into her legs. So, and you have the waddle, because as humans walk, we rotate a little. So you have this mass in the front that's rotating back and forth, and you get the full-on pregnancy waddle. Yeah.
So why do pregnant women get hemorrhoids?
Um,
Because everything's pushing on it?
Yes, and there's another reason they do. The baby is pushing on the vena cava, that big vessel in the back, and that elevates venous blood pressure, which makes the veins dilate, and that's what hemorrhoids are dilated veins. So it isn't just the pressure on the GI tract and on the anus, it's also increased venous pressure. It's why like varicose veins and stuff happen in pregnancy too, because the baby is squishing the vasculature in the back. So why all this? Why don't we see other animals, with these problems? And it's evolution. The way we evolved is, we're all brain, essentially. How have humans been so successful on Earth? Big brain, right? Big brain means big baby. So we're sort of at the edge, evolutionarily, of the offspring development. We have the largest infants for our size of anything in the animal kingdom. So it's sort of tight in there. All right. Another good new one. So what else changes? Okay, that one's obvious. You got a giant baby in your abdomen. But there's a lot of other things that change too. So one is the respiratory system. So every system in the body is affected during pregnancy for the pregnant female. She's breathing for two, quite literally. So her respiratory rate and her tidal volume both go up so that she's bringing in more oxygen, getting rid of more CO2, right? In the mammary glands, we are developing the duct system. We're also developing those actual alveoli, the glands that are going to produce the milk eventually. And then when prolactin is triggered by the drop-off of estrogen and progesterone, then milk starts to be made. In the kidneys, she has to get rid of waste products for two. So her glomerular filtration rate is going to go up by about 50%. So mom is going to make more urine, and that urine is going to have more waste products in it, right? So not only is baby pushing on the bladder all the time, but she's also making more urine. So her urine output is higher. So you have that sort of double whammy, And let's see. This we kind of already talked about. The uterus gets huge, obviously. Of interest, though, is the number of cells in the uterus doesn't change very much between non-pregnant and pregnant. So what's happened is it's not that there are many more cells, it's all the cells have gotten larger. So the smooth muscle cells get larger and account for, we go from 3 inches in length to 12 inches in length, 30 grams to 1,100 grams. And that's just the uterus, that's not the baby inside, right? Yes?
How long after delivery do your organs go back into where they are?
The uterus is amazing at this. It goes from giant to very small in minutes, usually. So it shrinks back down, the uterus does. And as that happens, then your liver and digestive tract get to resume their normal thing.
I swear mine never were normal.
I don't think they know they're right.
You don't what, think your kidneys are
I don't know, I don't feel like stuff is right.
I never went back.
There are things that can get moved and not moved back, that's for sure. But the mobile organs, like the digestive or like the liver and those, should come back as the uterus shrinks. All right, let's see. So uterus gets bigger but doesn't get more cells. The digestive tract, she's got to eat for two, so maternal food instincts usually go up by about 30% when we take in 30% more calories. And then the cardiac output. So the baby and the placenta to the mom's cardiovascular system looks like a new organ, right? An organ that didn't used to be there but is now there, taking blood, taking nutrients, all that. So the response to that is mom has to create more blood to allow for the blood that's going through the placenta. So her blood volume goes up by up as much as 50%. So on the day of delivery, mom has much more blood volume than she needs all by herself. So, when you see a delivery, there's always some blood involved, right? But nobody's hanging blood, right? They're not transfusing blood. It's because by the time you get to delivery, she could lose 50% and still be fine. So you've had a major increase in blood volume. All right. And then our last two topics, parturition, occurs in 3 stages, right? Stage 1, stage 2, and stage 3 is how people usually talk about them. But the new names are the dilation stage, expulsion stage, and placental stage. And what's interesting is all 3 of these occur in the same way. The uterus is a one-trick pony, so to speak. It knows how to squeeze, and it knows how to push. So that's how it does all 3 things, right? So before the baby can emerge through the birth canal, the cervix has to get opened. You remember that the cervix, here it is here, it's kind of a thickened area, right? And it's got a plug in it called a mucus plug, and the baby has to get through this. So first thing we need to do is move the cervix out of the way. So the uterus contracts around the baby and essentially pushes, typically the baby's head, up against the cervix. As that occurs, first the cervix flattens, and then the cervix starts to open. So there are 2 different changes to the cervix that we look at, and that is effacement is the flattening of the cervix, and then dilation is its opening. So typically in the first stage of labor, the woman the cervix is checked for those 2 things because it shows you how labor is progressing. So, effacement is how thick it is, dilation is how open it is. So typically what happens is effacement occurs first, and then once effacement is complete, then dilation starts to occur until the cervix is open enough for the baby to emerge through. All right, so once the cervix is flat and open, usually 10 centimeters open is considered complete, then we move to the second stage. And again, uterus, one-trick pony, it's the same thing. It's going to contract around the baby. It's going to push the baby's head out now through the birth canal, right? So in the human, there is an angle. Do you see how there's sort of a down and then an up? So when you watch a baby being born vaginally, you'll see this angle come into play because it's sort of down, twist, and up. So there's a down and up to it. And after that down and up, the baby's out. The cord, at least in this country, the cord is clamped and cut. And then as the baby, now all of the attention in the room is on the baby, right? As all that's happening, the uterus is still doing its one trick, and that's contracting, and it pushes the placenta out. Yes?
I'm sorry, I gotta ask, why in this country? I was just.
Because in other countries they don't tie the cord. There's other ways to do it.
What do they do?
And some will bite it.
What?
Mm-hmm. I mean, that's what your dogs and cats do. So it isn't crazy. But in the Western world, we do it all nice and sterile.
Well, and you know what?
But there are other ways.
We're like the only country that still circumcises too. Really,
Right.
they've even shown that, besides people just wanting it to look a certain way, it's really not.
That's
about-
exactly, it's cosmetic
Yeah.
surgery.
It's not even about hygiene anymore.
Right. I used to do circumcisions, and I hated it because I felt like it was just a terrible
It's
thing to do to this
mutilation.
boy.
I can't believe I did it to my kid.
Yeah. And I used to talk to dads, particularly and moms, trying to talk them out of it. And man, in the end, no, we want to do that. Okay.
You know what? I have some older patients that are not circumcised, and the stuff that gets trapped in there is really nasty.
But you have to
They're
teach them.
sick. You have to teach them how to
Yeah,
do
and
that.
it's a weird one because we live in a culture where most males are circumcised, so there isn't anybody around to teach boys, and that's why, I used to sit down with the fathers and tell them, we don't have to do this. I can tell you everything you need to know about what to teach your boy about it. But, all right, so the placenta is born or ejected. The uterus continues to contract, and that's a critical piece because the uterus contracting is what's going to stop the bleeding from the release of the placenta. So, again, in obstetrics, after the delivery, you'll see the nurses rubbing on the uterus, rubbing on the lower part of the abdomen. The mom is pissed because she hates that. It hurts so bad.
they're doing that to get that uterus to contract down, because if it doesn't, you're going to keep bleeding. She'll keep bleeding.
Our
So-
nurses used to getting hit then because I accidentally hit mine.
Yeah, yes, they know that nobody likes that, but it's necessary. All right, we're out of time, so we'll stop there. And I guess we were done. We talked about lactation before anyway. We might cover those last couple of slides next time.